Good afternoon, everyone. I hope you had a fulfilling lunch. Post lunch, it's unnatural to feel a bit relaxed and drowsy. To drive away that drowsiness and infuse fresh energy into the hall, we have an exciting cultural performance lined up for you.
Dance is a universal language that reflects energy, tradition, and celebration. Punjab is known for its vibrant culture, infectious energy, and rich tradition of celebrating life through dance and music. Reflecting this lively spirit, we are delighted to present a Punjabi dance performance by our talented students. I kindly invite the students to the stage and bring alive the colors and rhythm of Punjab. Please welcome them with a warm round of applause.
ਬਦਾਮੀ ਇੱਕ ਲਾਟ ਵਰਗੀ ਕਿੰਨੇ ਸੀ ਮੈਂ ਦੇਖਿਆ ਹਲਾਕ ਕਰ ਗਈ ਕਿੰਨਿਆਂ ਦੇ ਦਿਲਾਂ ਤੇ ਚਲਾ ਗਈ ਯਾਰੀਆਂ ਜਦੋਂ ਜਾਂਦੀ ਜਾਂਦੀ ਮੇਰੇ ਨਾਲ ਗੱਲ ਕਰ ਗਈ ਕਰਦੀ ਸੀ ਪਤਾ ਹੱਥ ਉੱਤੇ ਟਾਈਮ ਦਾ ਦੂਰ ਜਾਂਦੀ ਦੇਖ ਮੇਰਾ ਦਿਲ ਸਹਿਮਦਾ ਕਹਿੰਦੀ ਮੈਨੂੰ ਮੇਰੇ ਕੋਲੋਂ ਹੱਥ ਜਾ ਛਡਾ ਕੇ ਹੁਣ ਜਾਂਦੇ ਹੋ ਗਏ 9:45 ਓਏ ਹੋਏ ਨੀ ਤੂੰ ਸੋਹਣੀ ਬਾਲੀ ਕਰਦਾ ਦਿਲ ਮਿਲਣ ਨੂੰ ਕਾਲੀ ਕਾਤੋਂ ਤੂੰ ਡਰਦੀ ਕੁੜੀਏ ਲਾ ਲਈ ਮੇਰੇ ਨਾਲ ਜੇ ਯਾਰੀ
किरिस का सुनने का गाना किरिस का सुना That's the wrong number.
लाके लोगड़ी ते गुत्त नाल फुल्लनी किसे जट दा करेंगी दीवा गुल्लनी लाके लोगड़ी ते गुत्त नाल फुल्लनी किसे जट दा करेंगी दीवा गुल्लनी मुंडे पिंड दे कुआरे पट्टे जाणगे नी सारे पिंड दे कुआरे पट्टे जाणगे नी सारे जदों निकली पटोले वांगू फब के जदों निकली पटोले वांगू फब के नी जट नूं दे हुंदा मारदा जदों हसी नी तूं कपे अख टप के नी जट नूं दे हुंदा मारदा
रुको जरा सबर करो
कैमरा दे नाल तोलदा
Nothing beats a jet, 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 jet.
Thank you, students, for the energetic and vibrant dance performance. Your graceful movements and lively expression truly reflected the rich culture, joy, and spirit of Punjab. A big round of applause for their wonderful performance. Let's move to the last academic session of the day, making an important conclusion to today's deliberation.
It's with great honor and pleasure that we welcome the esteemed chairperson for this session, Dr. Mona Lisa Patnaik ma'am, an eminent academician and distinguished leader in physiotherapy. With due respect, I request ma'am to please come forward and be kindly chair the session. Dr. Satyaki Gupta. I am honored to introduce an renowned leader in the field of physiotherapy on stage. With over 25 years of distinguished experience in pediatric neurorehabilitation and orthotics and awarded for Best Allied Health Innovative Practice, he has made substantial contributions to patient-centered care and clinical proficiency. Dr. Satyaki Sengupta, sir, Deputy Director of Allied Health Service and Senior Principal Physiotherapist at Kendang Carabao Women's and Children's Hospital, Singapore. Today, he will be delivering an expert discourse on conservative management of idiopathic scoliosis, a topic of considerable clinical importance. On behalf of the organizing committee, I request the delegates to join me in welcoming Dr. Satyaki sir to grace the stage.
Hello. Okay. Oh. Thank you. Thank you for inviting me for this topic in this conference. I'm really very glad to be here, especially in NITAR, since I started my career in NITAR after I did my master's degree in Haji Ali. So hope this presentation will be helpful for you all guys. I'll start the presentation. So conservative management of idiopathic scoliosis. So initially I will go through some of the initial basics of scoliosis, which I'm sure all of you are aware of. So basically scoliosis can be defined as a three-dimensional torsional deformity of the spine. And normally scoliosis, we may have a scoliosis, but if the angle, the Cobb's angle is above 10 degrees, then only it is classified as scoliosis as per SRS. That is a Scoliosis Research Society, right? So this is a body, international body, who deals with the study and the interventions, and it's a gathering of orthopedic surgeons and allied health professionals. So I'm sure you are aware of there are various kinds of scoliosis that we have. Idiopathic scoliosis, I think it's 80% of the patients that we have are idiopathic, and I think you all know what is idiopathic unknown. So within idiopathic, we do have some subtypes like infantile, juvenile, adolescents, and adults. So within these groups, I think the infantile and juveniles, we don't see much, but they are very progressive. I think most of us see a lot of adolescents idiopathic scoliosis and lesser of adult scoliosis. There is a kind of adult scoliosis we see in geriatric patients. I think that's a different version. We do also see scoliosis in neuromuscular patients, like cerebral palsy, syringomyelia, and other. Also, we see in different type of patients who have muscular dystrophy, arthrogryposis, and congenital hypotonia or SMAs. These patients also do have scoliosis. Because the etiology of the scoliosis is different, their management is pretty different, then the approach of the management is very different from how we approach the management of patients with idiopathic scoliosis. Actually, the approach of management in infantile scoliosis is also quite different. So we will focus today on idiopathic scoliosis, but I'll be happy to answer questions of the other groups as well. And we do have some variety where we know that it's called congenital scoliosis, where we get because of bony abnormalities that are present, such as wedge or hemivertebra. If they're balanced, they're fine. If they're not balanced, then we have patients with scoliosis. So I think most of you have seen scoliosis. You'll see that postural asymmetry is something which normally we see initially, right? There is a tilt in the head, uneven shoulder level, rib shape, waist shape and angle. Pelvis and rib cage may not be symmetrical, and there can be different prominences when the patient or the child bends down because of the three-dimensional deformity that we know scoliosis has. That is a lateral curvature with a rotational deformity, and when it happens in the thoracic spine, it moves the thoracic cage, and then we see a lot of different prominences. Like if you see from the back, the scapula may be prominent in one side, the thoracic cage may be rotated. Similarly, the pelvis can be rotated as well, all right? So these are the different prominences. Leg length discrepancies, sometimes it may lead to scoliosis, but sometimes it may be there because of the pelvic obliquity that we have, right? So I think basically we all know that scoliosis, primarily we want to we know that they are structural and functional. So functional scoliosis are scoliosis that we see. Actually, we had some discussions earlier in terms of scoliosis from sciatica and all this. So these are functional scoliosis where normally it gets corrected in front Adams bending test. So the forward flexion test, which is the Adams test. So there is a prominence on the convex side. That's a clinical assessment that is a must for scoliosis. Although it is not very sensitive, but if the anterior trunk rotation, ATR, is above 5 to 7, then only we classify it as a scoliosis. This is a test that in many countries are used to screen school children because scoliosis is very prevalent in teenage and especially in girls. So in many countries, the school, they screen the kids, and whenever the ATR is above 5 to 7, then they are sent for screening, more detailed screening. So functional scoliosis, it's primarily secondary to extra spinal causes. It is not spinal, but there can be other reasons where a patient may present with a scoliosis. Structural, 20% related to medical conditions which are neuromuscular, and 80% normally are idiopathic. So this is a similar slide to the previous one. So I think it tells the groups within the idiopathic scoliosis. So what are the assessments that we do? Definitely we do physical assessments for scoliosis, but we do very objective assessments as well. So I think in terms of the objective assessment, I think one of the most important is the Cobb's angle. All right, there are various ways of measuring scoliosis angle, but the Cobb's angle is normally the norm that is being followed internationally to determine the severity of the degree of. So over here we have, if you see this yellow box where a girl is standing, this is called an EOS. This X-rays are primarily developed for X-rays for scoliosis and spine, which are extremely low radiation because these kids have to undergo at least, some of them, 3 monthly to 4 monthly skeletal X-rays. So exposure to radiation is very important, especially they are in teenage. So if possible, it is better to use a low radiation X-ray, which is called EOS, and you can take a whole body sciogram so that you can also try and measure if there is any leg length discrepancy within the X-ray itself. All right. So Cobb's angle, and the next thing which is important is the research sign, is a sign of skeletal maturity. Why skeletal maturity is important? Skeletal maturity is important because when we are talking about idiopathic scoliosis, we have a window to work with them. And this idiopathic scoliosis normally grows when the kids go on the second growth spurt. And to measure the growth spurt, how we measure the growth spurt? So one of the way of measuring the growth spurt is taking an X-ray of the pelvis and looking at the ossification of the ilium. So that's how it is measured. So it's measured research 1, 2, 3, 4, and 5. So normally research 0 to 3 is the stage where they do have significant growth. And if they come with a significant curve at this angle, we have to look at them and track them to see and how they are progressing, number one, and whether we need to and when we need to intervene in terms of what we do with them, how we manage those patients so that we can at least try and reduce the deformity. So normally in scoliosis, the intervention is not directed towards curing. It's the direction of the intervention is managing the curve to a manageable degree so that the postural variations and the postural asymmetry is less, number one. And number two, if we can avoid a surgical correction, all right? So normally surgical corrections are done for corpse angles which are above 45 degree. So if we can keep the total corpse angle below 45, we can avoid surgery. But if we can keep them even lower, it is even better, because then they don't have postural asymmetry. And then, because most of them are girls, so I think when they grow up, they can choose what they want to wear and so forth. So other things that we also should look at is the vertebral rotation, leg length discrepancy, pelvic obliquity, and the overall sense of posture. So this is what I was telling in terms of the skeletal growth. So we know that there is an ideal window. So if you look at the chart over there, there is a peak growth velocity. And the ideal window of opportunity where we need to focus our intervention. And to do that, we need to check what is their skeletal growth and how we are going to manage them. So this is a curve. So this patient who was being followed up, but I think there are three sessions they missed between 11 years and 12.5 years, and where suddenly there is a sudden increase in the corp angle, right? So for patients who have idiopathic scoliosis, we need to continue to see them till they are fully skeletally mature. That means if they come to us at 10 years, we only can discharge them at 17 years. Till then, we have to at least see them depending on the progression, whether we see them 3 monthly, 4 monthly, 6 monthly, or yearly. So what are the risk factors for scoliosis? I think number one is female. If there is a family history, then definitely there. If there is an angle which is significant and the child is of age 12 years old, pre-menarche, because pre-menarche to post-menarche, this is the period where girls grow the max. And within this period is also we need to be very aware that if we want to treat the kids, this is the time that we have to focus the intervention so that the angle doesn't go. And any other corp angle that is above 30 degree and with growth remaining. So if there is above 30 degree and the child is reserved below reserve 3, those kids have to be seen with a lot of attention. So what are the aim of the treatment? So modulate curve progression. I think that is the first thing. Improve aesthetics, improve pain. Most of the time they don't come with pain, but sometimes they do have pain. Improve body image, acceptance of asymmetry, and improve quality of life. So basically these are the aims of treatment. So what are the treatment options that we have? So we can just observe the patient, regularly taking X-ray and nothing can be done, because functionally they will be fine. I don't think they will have any difficulty other than the deformation, because cardiopulmonary functions only get affected when corpse angle is beyond 65 degrees. Before that, once it is 65 and above, we do see some restrictive disorders of cardiopulmonary function. Observation, we can do scoliosis specific physiotherapy exercise. I think this is so we have been doing exercise for scoliosis for many years. I think previously we used to do Cortill's technique, elongation, flexion, and derotational technique. We used to put kids in traction. So wherever they had scoliosis service, I think a lot of these services were there. But it was not that evidence-based, because what we are looking at, the muscles of the paraspinal muscles are very small, and a lot of biomechanical studies was with the opinion that the therapy doesn't produce enough force to do a correctional movement with it. Bracing and surgery. So these are the options that we have when we want to treat patients with idiopathic scoliosis. So basically the KR model that is now quite established because also because of evidence, if the Cobb angle is 0 to 20 degree, observe progression, and the patient, once they are maybe around 15 and forth, can start doing physiotherapy, which is very specific to the scoliosis. 20 to 25 degree, they should have PT and brace if substantial growth is left. If they don't have substantial growth, then we may or may not give brace. 25 to 40, brace, physio plus brace. 40 to 45, brace is primarily PT and brace if still growth. And above 45, I think we still do physiotherapy and when we need to start talking about surgical intervention. So basically the treatment depends on bony maturation, what is the Cobb angle, and if there are other pain or other symptoms. Because sometimes if there is the lumbar curves are very acute, sometimes the thoracic cage can touch the pelvic and it can be very painful situation. So those cases we need to correct surgically as well. So what are the physiotherapeutic approaches? I think most of us know Rigo concept, which is from Scroth. Most of the concepts over here are basically developed from Scroth. Scroth in Rigo is from Spain, best practice is from Germany. Then the CS from Italy is also quite. So these are some of the practices that have shown to have evidence in improving or basically modulating the physiotherapy curves in idiopathic scoliosis. All right. But it does not mean that these techniques cannot be used in other scoliosis, but most of the studies that have been done have been done in idiopathic scoliosis. So the basic concepts of PSSC is education, active correction in 3D. So this is, so the patients have to actively correct the curve in 3D. Subsequently, we do stabilization of the corrected posture, and then how we transfer this corrected posture to do activities of daily living. So the principles are similar, 3D postural correction. So that's we have to do by expansion technique. So I think in Scroth, so one concept, so means I have not been doing, means I've been doing, being associated with scoliosis for quite significant, almost like over 10 years, but I'm doing the physiotherapy specific exercises for maybe last for 3 years. So one of the concept is very, initially when you hear it, is the expansion technique, because here they use breathing to stabilize the corrected position. All right, so that is quite different from the other therapy techniques that we have been used to using. Muscle activation, integration. And then subsequently we have to teach them how to maintain self-correction. I think this is specifically, I'm going to Scroth, which is the Rigo technique, which I'm certified. So this is, so if the angle is within this range, I think we can do surgery. Even if we can do PT, we can definitely do PT pre-surgery and also post-op. Post-op care is not so much of physiotherapy specific. It is basically the post-op care of a spinal instrumentation. So one of the principles of Scroth or Rigo that means I do practice is auto-elongation. So we have to elongate deflection and derotation of the spine, expansion and contentment. So these are very specific. For the specifics, the patient, we classify the spine. Once we classify the spine, then we actually do individually, depending on individual patients, how we do it. Asymmetrical sagittal straightening, increased frontal plane vectors, corrective breathing is, I think, most important thing. Muscle tension stabilization. These are the techniques that we use in together when we are using the scrub or the Rigo technique. So basically, we look at the spine as different blocks, and there where we do classify them, and depending on their classification, we will work with them individually in terms of, providing the 3D correction, stabilization, elongation, and how we stabilize them. So we put them in different positions so that we can, taking care, with the help of some of the equipment, which is similar to Pilates equipment, if you all have seen. And that's how each of the patients are taught the exercises. Then they have to continue to do the exercises at home, and then we follow up with them. So the basic steps are pelvis correction, auto elongation. So basically, if you look at the X-ray, these are the directions depending on the curve that we would like to do. All right. So where they have the convexity, we will try to focus the breathing on the concave side. At the same time, we have to auto-correct, derotate the spine, and stabilize the shoulder and the pelvis. So in this corrected position, we have to ask them how they can stabilize and stay as long as possible, or do the exercises in the corrected position. So this is what we do in asymmetrical sagittal straightening. So we need to give a lot of clue to the patient so that they can actively correct the deformity, stabilize the deformity, and do breathing to stabilize and open up the concave side. This is a very hands-on technique, and it takes quite a bit of time to get a hang of it once you do the training. I think it's similar to any manual therapy. Once you do it, when you study it, and when you start doing it, you need to internalize the concept and how it applies to the patient, and so that you can use it correctly. So as I was telling, we use vectors in the frontal plane, shoulder traction, shoulder counter traction, to stabilize the spine, and then do the 3D autocorrection. So these are the vectors that I think we have tried to draw, that depending on the curve, where we will focus our attentions. So corrective breathing, I think corrective breathing is something new. Even when I first did the course, it was quite new concept to me. And now I know why. So the corrective breathing primarily tries to, it's rotational and angular breathing. During inhalation, what we should do. During exhalation, what we should do. And so we maintain the corrected posture. So this is stabilization, which I was telling, that we need to stabilize the hip and as well as in the shoulder area. All right, and then we have to do the corrected posture and the corrected, I would say, the movements within the spinal column, and assisted by corrective breathing. So this is what happens when we are trying to stabilize I mean, since I tried to get a YouTube video because I cannot use my patient without consent. Yeah, you can just, then we come back to that. So then you will have a better idea because it's, yeah.
So one question I get asked a lot is, what are Schroth exercises? We use the Schroth method to treat scoliosis, and so thought I would show a few exercises that we do in the Schroth method. One thing to remember, these are not exercises I want you doing at home, or anyone doing at home until you've actually been evaluated. They're different for each curve, different for each type of scoliosis, and so this is just an example. Please don't take these and do them until you have talked to someone that knows what they're doing. So this is Paige. Paige is one of our awesome scoliosis patients. She agreed to come in and demonstrate a little bit about what she does. And I want to introduce you to her scoliosis curve as well. So Paige, go ahead and stand up and turn around and face that way. So as we do exercises, it's important to know exactly where the scoliosis is. So Paige has scoliosis that comes, she has a little curve up top, and then she has a curve that goes here to the right, and then a curve that goes to the left. So we have her shoulder blade on the right side is pushed back a little bit because her ribs are pushed back up here. Down here, the spine is rotated and pushed back because of the rotation of the spine here. So we have two curves. We have a little bit of a shift in her pelvis, so you can see a little bit more of a waistline there than here. And can you bend forward just a little bit, Paige? So if she bends forward, you can see more of a prominence here because the ribs are pushed back. And here on the left side, in the lumbar, we see a little bit of a prominence there too. So we have to take all of that into consideration. Go ahead and sit back up. I'll stand back up. This is a concave side of the curve, so that's going to be important as we do corrections. To open that up, and then this is her other concavity in the spine. So that's Paige and Paige's curve, and let's show a sitting exercise. Okay, so here we have Paige in a sitting position, and I have a strap on her knee. We're going to use that in a little bit. But she's sitting in front of these bars we call stall bars, just to help with the corrections. So I'm just going to go through the exercise, explain a little bit about what we're doing. So Paige, put your arms up on the bars. So she puts her arms uneven because she has a concavity up here in the thoracic spine. So the first thing we do is we want to get the pelvis corrected. And Paige, relax like you don't know what we're doing. There we go. So the first thing we do is we get the bottom block, which is the pelvis, in a good position before we try to stack any building blocks on top. So we have her lift her tail a little bit, and we have her shift over to the right just a little bit so that her trunk is centered directly over her pelvis. So then we're going to start with elongating the spine. So if we have an S curve like Paige's, and we grab both ends of the S and we pull, that S straightens out. So that's the first thing that we do, is we try to elongate the spine. So Paige, I want you to bring your lower ribs away from your pelvis, getting taller, expanding and opening. And then we focus on the concavities, really trying to create room and expanding those concavities. Push out at the elbows, this one a little more, as we're expanding and opening. So Paige does awesome with this. She's already starting to correct a little bit, but we're trying to create room. We're using breathing, nice deep breaths to try and expand the concavities, create room so we can do some corrections. Controlling the shoulders and the shoulder blades, and staying tall. Then we start focusing on one concavity, opening outward, backward, and upward. And then we take the prominence and we push it forward and inward. Good. And we come backward on the front ribs and outward. Good. So we can already see that prominence going down, keeping the shoulder blade back, pushing out at the elbow, keeping all of that. Put your hand on the pole and pushing inward, forward, backward, and outward, expanding and opening.
So I think
keeping the trunk over the pelvis.
So each of the patients, I think we have to classify the patients, and then we have to go through the patients individually, teach the patient exercises. We may be doing in sitting, we may be doing in lying, or sometimes we can use different devices to facilitate. And then subsequently, we also try and get the same equipments for them at home so that they can do it. Because if they don't do it and maintain it, then it will be very difficult. At our hospital, because we are a public hospital, so we can't see them every week. Because though Singapore is a small country with a population of 5 to 6 million, I think every month we may be seeing around at least 100 to 200 kids with scoliosis. So the number of patients that are referred to physiotherapy are quite high. Some of them may not need, but I think since the awareness is high, I think the parents are very anxious that something has to be done. We just cannot watch the kids. So the other very important part of the intervention of scoliosis is bracing. Actually, before physiotherapy that it helps had evidence, I think the bracing evidence came much earlier. All right. So most of the studies were done with Boston brace. Boston brace is basically a 3-point pressure principle brace, which is different from the current braces that are given. That's called the Chanute brace or the 3D braces. All right. But both type of braces actually work quite well. The only thing, if you are doing the 3D Rigo Chanute braces, they complement the therapy, because we classify the patients similarly and they can practice breathing and correction within the brace. So basically, these are the type of braces. I think this is Rigo, which is quite getting very popular nowadays. Only it is very difficult to get orthotists trained in this brace making. It is not as easy as doing Boston brace. So I think for the last 10 years, I put up these slides because I think from 2009 to maybe just till early 2020, actually personally I was doing this spine crow brace. This is a flexible brace for children with scoliosis, and actually we used to get very good results. We could give the brace on the same day. But unfortunately, because it is still very expensive, and we used to get the brace from UK. So, and once we started our own orthotic service, we discontinued this service. But we have very good studies which my colleagues and all we presented, and we had very good results with spine crow brace as well. So the other popular brace now is a Scoli brace, which is also a 3D brace, because these braces they do correction and then they do the bracing. So the correction is, so this is developed by an Australian chiropractor. So this is also getting a lot of popularity now. So these are some of the publications that, the physiotherapy is effective, because if it is not effective, there is no point wasting people's time and ours time as well. So this is a study that we did recently. I think our orthotics colleagues did this. This is the study with spine crow brace. I think it was done because a bunch of physios, we were doing spine crow brace because we had all these patients, and our ortho department was telling that we are doing nothing. Then few of us got trained, and then we started doing the brace initially, and our results were pretty good as well in terms of in preventing adolescent idiopathic, preventing them from going for surgery, which is almost like 80% of the patients that we braced never went for surgery. And even 60% of the patient, actually the corp angle increased within a range of 5 degrees within the span of the bracing that we did was for 2 years. I would like to acknowledge our physiotherapy department and pediatric orthopedic center. Yeah, maybe I have a YouTube video for a brace, so maybe that can be, yeah. Yeah, second. Yeah, yeah. So I just wanted to highlight that. So basically, that's how we are doing the braces. We are trying to cut down all of the cluster works. So basically, the scan and measurements are taken by an orthotist, and then CAD/CAM software is used to modify, and then it is milled, and subsequent once it is milled, then the brace is fabricated in the orthotic workshops. So there are possibility of doing 3D printing. Then I think we have to see whether we can make it more affordable and it can be done at the turnaround time can be quicker, because if you have a child with scoliosis, we don't want them to wait for 3 to 4 weeks for a brace to be manufactured. If it can be done within 2 to 3 days, then I think we can start the intervention pretty quickly. Thank you. So I'll be happy to take any questions that you all guys have.
Thank you, sir. And any questions from audience? Sujata madam, do you want to, because she has done her PhD in scoliosis, do you want to ask anything? So thank you, sir. Really, it was very enlightening. And thank you so much. You have come from so far for us.
Thank you. Thank you for inviting me. Thanks.
Thank you, sir, for the comprehensive and scholarly presentation on conservative management of idiopathic scoliosis. Your insights have significantly enhanced our understanding of evidence-based non-surgical approaches in clinical practice. Thank you once again, sir.
We will now proceed with the felicitation of our honorable speaker. I request Dr. Patitapaban sir to kindly felicitate our esteemed speaker, Dr. Satyaki sir. We shall now proceed with the felicitation of our Honorable Chairperson. I request Dr. Patita Paban sir to kindly felicitate Dr. Mona Lisa ma'am by this souvenir as a symbol of our respect. We will now pause briefly for a presentation of assessment by Dr. Sarhan and team from Grand Slam Fitness onto the stage. I request Dr. Sarhan and team kindly come onto the stage.